everyone. My name is Raj Narayanan. I'm an interventional radiologist, interventional oncologist at the Miami Cardiac and Vascular Institute and Miami Cancer Institute. Today it's my pleasure to welcome our esteemed audience here today, where we're going to discuss irreversible electroporation in detail. I'm joined here today with Dr. Praveen Peddu from King's in the UK, Professor Tze Wah from Leeds, also from the UK, Professor Martijn Meijerink from Amsterdam UMC, and Dr. Varshana Gurusamy, an assistant professor in interventional radiology at the MD Anderson Cancer Center. So I'm delighted to have this discussion with them. In the next hour, we're going to look into different aspects of irreversible electroporation and how this technology has played a role in interventional oncology. And so we'll first start with a little bit of an introduction to the technology. Irreversible electroporation is a non-thermal ablative technique. It's been around about a little over 15 years, where we use high voltage, low energy DC current to create permanent pores in cell membranes that leads to cell death. Since its introduction, it has found different applications, and we'll now start with the liver, one of the most common areas where we use IRE. Prav, let's start with you. You work at a transplant center in King's and you use IRE along with thermal ablation and HCC. So what is your criteria? When do you pick IRE and when do you use microwave?
So I think for all the early stage HCCs, small tumors less than 3 centimeters, our primary objective is cure. So we would use thermal ablation for majority of those. But in those patients where we think thermal ablation is high risk, particularly central lesions or lesions next to bile ducts, or in places where we think thermal ablation is going to be suboptimal because the lesion is very close to a major vessel like IVC or major hepatic vein, where you think heat sink is going to be a factor in getting margins, in that situation we tend to use IRE. So I think, in summary, I think thermal ablation is our primary treatment of choice, but IRE is a kind of a troubleshooter when we think we're going to treat high-risk lesions, or when we think thermal ablation is going to be suboptimal.
Okay. You recently published an article on small HCCs and treating them with IRE. Can you talk to us a little bit about that study?
Yeah, it's a study which I always wanted to publish, because when we first started using IRE back in 2014, we weren't sure about the lesion size we can treat, and we were also not sort of entirely clear about the technique. We were trying to use 2 needles and then replace those 2 needles, but after a period of time, we sort of found the way to use the technique. So this study is essentially, once we sort of nailed on our technique, and also once we made sure our inclusion criteria are solid, so that's when we started looking at those. So from 2015 onwards to sort of 2019, late 2019, early 2020, we collected 54 patients with 56 tumors, and we had a median follow-up of almost 3 years. And we looked at the outcomes, primarily, the primary success rate, 1 year progression-free survival, and also 2-year progression-free survival. And we found that majority of these patients who were unsuitable for thermal ablation, who had anatomically challenging lesions, we managed to get very high primary success rate, well in excess of 85%, and also a good 1 year and 2-year progression-free survival. So in effect, we found out that it's effective, and it's also, the response is quite durable. And that's the message we wanted to send out, and that's the message we wanted to know for ourselves, and also to give it to the rest of the community as well. The other aspect of that is, we always had a feeling that IRE is more invasive. So you're putting multiple needles instead of 1 needle for thermal, and by that you're implying that you're going to cause more complications and more serious adverse events. But in our study, we did not find anything in that sense. We only had about 7% complications, of which I think 4% were major. So it's very much in line with the published literature in terms of thermal as well. So overall, I think it's effective and it's also safe. That's the inference, yeah.
So in your multi-D tumor board, when you talk about ablations in the liver, is there a discussion on which modality to use? Is this driven from an MDT discussion?
Well, absolutely. I think everything is MDT driven discussion. So, and everybody is obviously, we consider patients whether they're suitable for transplant or surgical resection. In the first instance, if those two are not options, or those two are still options, we would still consider ablation or other modalities as an adjunct, or to make sure the patients remain within criteria when they eventually come to the transplant. And in those patients who cannot have transplant or surgical resection for a variety of reasons, we would tend to consider the curative approaches first. And for small tumors, the curative approach is an ablation, whether thermal or non-thermal. So it's very much an MDT-driven discussion as to choosing the right patient for the right place. And whether or not IRE versus thermal, I mean, our clinicians now know what our choices would be, so they automatically recommend IRE for tricky tumors. But it's very much in initial phase us directing what the modality of choice would be. So yeah.
So Martijn, one of your major accomplishments, one of several, is the collision trial, which is changing and will continue to change how ablations are used in metastatic colorectal cancer in the liver. But since this discussion is on IRE, we'll discuss your coal-fire study where you looked at the role of IRE in metastatic colorectal cancer. Can you talk to us about the coal-fire study?
Yeah, so actually the cold-fire studies, they predate the collision trial by many years. So this dates back to 2011, 2012, when we started a program, and everybody, including myself, was very skeptical. Are we going to completely eradicate cancers using electrical pulses? So we needed to validate that, and we set up a very small cold-fire 1 trial. That was long ago. It was resectable colorectal liver mets that we first treated with IRE, and then 2 hours in the OR, and then 2 hours after the IRE, the surgeons resected the tumor. And the idea was just to check, was that tumor completely eradicated? Was the cell kill 100% in the ablation zone? And if I remember correctly, I think out of the 9 tumors that we could evaluate, 8 had let's say, complete response with no residual viable cells. And that led to the cold-fire 2 trial, which was a clinical trial for pretty similar indications like in HCC, for unresectable and not thermally ablatable central colorectal liver mets up to 5 centimeters. After including 51 patients, we predefined, this was a prospective trial, we wanted to have at least 50% of the patients at 1 year follow-up having no signs for any local recurrence. So they have to be alive with no local recurrence, and there was no chemotherapy that we could give. And it had to be over 50% because the alternative here, there was no alternative, it's chemo alone. Remember in the old days, maybe SBRT. And the results was actually way more than the 50%, and it's a long time ago now, but even then we had 68% after the first procedure. And of course it's a procedure that you can repeat, similar to most techniques that we have. So including repeat ablations, repeat IRE procedures, we managed to get local control up to 74%. So not as good as what we currently have with thermal ablation, so similar to, I guess, everyone here, that goes first, but if that's not an option, 74% is a good number. And maybe if I have a little bit of time, so we're currently running the cold-fire 3 trial, because I think that SBRT, radiation oncology, did not stand still as well. There's a lot of people advocating for that as well. So we're now making a direct comparison for tumors, similar indications, eligible for both SBRT and IRE, and we're comparing that. But we have now 7 patients in the trial, so it will take a couple of years before we have the answer.
Well, that's great, but once again, patient selection plays a role when you look at thermal ablation versus IRE. So it's not really an apples to apples comparison, because thermal ablation, we can use it in locations where you don't have critical structures. And so that's great. Z, do you use IRE for metastatic colorectal cancer in your practice? And when do you choose this over thermal ablation?
Yeah, similarly, we have IRE in our practice and always discuss in the liver MDT. So for those patients that usually they are non-surgical patients and they're centrally located. In fact, our SBRT practice is quite avid in our MDT. So whatever that is not suitable, patient centrally located tumors, there's no other options. usually those are the cases that we treat. Yeah.
Martijn, you also have done work on using arterial enhancement before ablating colorectal mets. Do you do that when you use IRE too, or is it only with thermal ablation?
We do that for all ablations, even in the pancreas, but maybe we'll cover that later. But for the liver, we always do that because obviously you want to avoid having the needle go into the portal vein or the hepatic artery. So it helps you, with a safe approach for the needle, but also the conformation. I mean, similar to, I guess, to thermal ablation, the ablation zone is surrounded by a hyper-enhancing rim after the IRE. So you can beautifully use that and plot that scan after the IRE over the scan pre-IRE and similar to thermal ablation, verify your margins.
Okay, great. So switching gears, Varshana, you work at one of the premier cancer centers in the United States, and what is the workflow that you and your team follow at MD Anderson when you see ablation patients, and how do you decide about IRE? Is this more of a recommendation from an IR, or is it driven in the tumor board?
Yeah, so we see a lot of these patients in multidisciplinary tumor board. The recommendation, like you were saying also, in terms of the modality, comes from the IR. It's really driven by the IR, whether it's going to be IRE or microwave or whatever it is. Once we've seen a patient in tumor board, or they've been referred to us maybe by radiation oncology, then that patient will be seen in a pre-clinical or pre-procedure clinic visit. And we typically see, the MDs will see all of these patients about 2 weeks before. I think it's super important for the actual physician and not just the physician assistant to see these patients and kind of have this lengthy discussion about what to expect during the procedure, especially with pancreatic IRE. So we see these patients in clinic. We kind of go through all of their pre-procedure assessment, qualifications for anesthesia. And in terms of approval for the procedure, we have a lot of support at MD Anderson, a lot of administrative support. So all of that gets done before the patients, not before they're scheduled, but we make sure that it's approved about a week before they're scheduled. And if for some reason their insurance denies, and we have resources to write letters of medical necessity, we have a few already that we've written, but we make sure we have approval about a week before the procedure is actually done.
Right. So there are a lot of IRs who finish their training, and when they go into practice and they want to start programs, say ablation or more specifically an IRE program, sometimes the usual comment is, how do I go about getting this program started? You trained with us at MCVI and you went on to MD Anderson, and what was your experience, and how did you go about getting a program started? What kind of advice you have for young IRs?
So wherever you trained is probably very different from where you'll practice, and I think some of the best advice I got from maybe you and some of my other attendings at MCVI was, the first year that you're there, you really need to understand the landscape. You may have these ideas, like, I'm going to come in and build a pancreatic IRE program, but maybe nobody wants you to do that, or you don't understand the playing field. So it takes time, first of all, as a new attending, to just get settled and understand how everybody's working together. Is there an opportunity to build this? Do people even want you to build this? Does your chair support it? I was very lucky when I came to MD Anderson. We had the IRE equipment. This was an area that they were hoping somebody would build. So that I came into a very nice situation, but it's not always like that when you're building a program. And then I think once you establish, okay, there is some support from my own department, then it's looking at who are the stakeholders, how involved is surgery and radiation oncology? Are they going to work with you, send you patients? We're very lucky that we have a lot of support in that area, and we get a lot of these patients from tumor boards. So that's sort of how it's worked out. But it's always a moving target. I also was really lucky to have one of my partners already interested in pancreas IRE, so there's two of us. I work in a group of 30 IR physicians, so it's nice to not be the only person building the program. So I have another partner who does that, and it's nice to have that presence as well in tumor board from both.
Great pointers and a perfect segue to move into pancreas. So when you went there and you started getting involved with treating patients in IRE of the pancreas, how did you go about it initially? Was it through communications with the medical oncology, radiation, surgery, or all of them?
It interestingly came from radiation oncology, and it wasn't pancreatic adenocarcinoma in the beginning. It was, we were getting these kind of strange cases of metastatic sarcoma to the pancreas, patients that had been radiated in the field, they'd exhausted all their other treatments, and so they asked, is there anything that you can do? And once we started to do a couple IREs of sarcoma mets to the pancreas, and we started getting a little bit more pancreatic adenocarcinoma. But we're still building the practice, and I would say your practice is never built. You're always it's always continuing to evolve. But that's sort of how it started.
So you see, assume you see all of these patients in clinic, and what kind of imaging or pre-procedure criteria are you looking for?
Yeah, so we see all these patients in clinic. I'm lucky again to work at a cancer hospital where the patients get very frequent imaging. So basically I'm looking for a CT that's pretty recent, at least within a month or so of the planned IRE procedure. And we'll talk to the patient about, whether they can undergo the procedure from an anesthesia standpoint, those types of things. We get, lab values, CA19-9, other, general lab values, coags, things like that. And then I have when I see the pancreatic IRE patients in clinic, I book extra time because I think this is a little bit more complicated than the average ablation maybe. And you really have to talk to them about the possibility of post-procedure pancreatitis. They may not go home the next day. They may stay with you for some time. And so I really take a lot of time to set expectations, go through the imaging with the patient, and also I send a lot of imaging back to the oncologist, say this is what we're going to do, this is where I'm thinking of placing probes. I try to involve them as much as possible in the procedure, and I think that helps build a relationship, which goes back to building a practice. When they say like, oh, this physician is the one that's going to talk to me about the procedure, involve me in it, they're not going into some black box where I don't understand what happened. And then kind of going into the day of the actual ablation, so we do have the patients do a bowel prep the night before. That's one thing to mention. And so you also have to get the patient on board with a lot of these things. A bowel prep, they're going to get a nasogastric tube the day of the procedure. That's helpful to give oral contrast. We talked about that. And, explaining again to them that they would stay for a certain amount of time possibly. I used to do the majority of these procedures. I guess I did all of them with general anesthesia, but after having jet ventilation, that's really been a game changer. And then now I think with robotic assistance, that kind of can lessen the amount of time it takes to place the probes, which is a very challenging part of pancreatic IRE. So now I've kind of moved to a practice where I'm using jet ventilation. On the day of the procedure, I get a triple phase CT scan. So we have a non-contrast arterial portal venous phase, and sometimes even a delayed venous phase before even placing the probes. And then after placing the probes and doing the ablation, we'll get another scan on the table to you don't always see a great ablation with pancreatic IRE, but sometimes you can see kind of a zone of ablation, so it's nice to have that.
So then you admit them, I guess, all your patients get admitted, and that's typically what we do too. We keep them overnight. The next morning we check the amylase and lipase, and if it's normal, we remove the NG tube, and then advance their diet, see how they tolerate it, and then get them ready for discharge. So technically, what do you feel is the most challenging part in IRE of the pancreas? Because the pancreas seems to be an organ which still makes a lot of IRs nervous, rightfully so. because this has typically been in the space where it's only been surgeons who go there, and clearly they have the advantage of having the patient open. They can fix anything that is a problem. So as an IR and somebody who's doing IRE of the pancreas, what do you feel is?
I mean, when you do a surgical internship, the first thing they tell you is don't touch the pancreas. So it's kind of an interesting switch in philosophy. The pancreas is a really high real estate area. The organ itself is delicate, and there are large mesenteric branches, SMA branches, there's small bowel. And with IRE, it's nice in a way that you can traverse some of these structures like the stomach and small bowel, but large bowel can pose an obstacle, and of course blood vessels. So that I think the most difficult thing about doing pancreatic IRE is just the nature of its location and being able to place the probes in a very small window. It's always a small window no matter how you slice it, and then having to place the probes in parallel. So that I think adds a lot of time to the procedure, a lot of planning, but there's ways of mitigating that and kind of moving structures out of the way, but that's probably the most technically challenging part.
Great. Prav, your experience with IRE in the pancreas is different. You do it in the operating room. You work with the eminent hepatobiliary surgeon, Chris Mayman. So what is your experience, and how do you all go about this combination of both of you working in the OR?
Yes, I think we have started doing the intraoperative IRE for pancreas almost for about 6 to 8 years now. And I think how it all started was we always had a good working relationship with our surgical colleagues. We were involved right from the time of the diagnosis towards treatment planning and defining what is resectable and what is inoperable, etc., or what is borderline operable. So when IRE first came out of the scene, myself and a colleague of mine, the surgical colleague of mine, Professor Menon, we came to see Rob Martin here in Louisville, and then we learned the art of doing margin accentuation prior to doing the pancreatic transection. And that's why we picked up the technique, and then that's how we sort of took it back to our own institute. And now we do two sets of cases. One, we do patients who are borderline resectable. We give them a few cycles of chemotherapy to assess the biology, and if they remain stable without sort of progression, then we go ahead and do a margin accentuation followed by Whipple's resection. And in some of these patients, when you actually take them into the operating room, they may not be operable, although on CT you would think they're still potentially operable. They may not be. In that cases, we tend to do an in situ IRE on the table. So the decision is made in the MDT setting, but then once you go to the operating room, then we either go in margin accentuation or an in situ IRE, depending upon the intraoperative resectability. Yeah.
I mean, do you do more patients de novo or for margin accentuation?
I would say majority of the patients still go ahead with margin accentuation. We have the good fortune of working with our transplant surgeons who are very capable of doing vascular dissections and using jump grafts and things like that to replace vessels. So they're quite comfortable doing that. So majority of our intraoperative procedures are still margin accentuations. I would say about 40% of them are in situ ablations where they can truly inoperable with the tumor tracking all the way down to the SMV branches, well down into the root of the mesentery, or significant arterial involvement.
So what advice or pointers do you have for IRs who want to work with their surgical colleagues or to be involved in an IRE of the pancreas program?
I think I was very fortunate enough to work in a center where there was a very strong working relationship between the surgeons and the interventional radiologists. Because our surgeons are also the transplant surgeons, so we're involved in every aspect of our patients. We're involved in the living related donor program where anatomy is quite critical, so they rely heavily on our sort of guidance for the anatomy. And similarly for the oncological practice as well, they're very much reliant on ours sort of defining the anatomy for them for resectability. We often go into operating theatre to help them, to identify margins, resect tumors, liver, pancreas, etc. Sometimes doing intraoperative ablations as well to help with the surgical resection. So the working relationship has always been there. And that sort of translated into the next development, which is the pancreatic practice. So I think my advice would be for any new IRs to have a good working relationship with your surgical colleagues, and be helpful for them, be able to answer the phone whenever you are. So we pick up the phone whenever they call me, whenever, regardless of whether I'm in the country or not in the country, sometimes to ask for an opinion on whether something should be done or whether, etc. So having that sort of confidence in each other is important right from the outset, and that'll translate into close working partnerships, and then ultimately I think that'll translate into better outcomes for the patient.
And from a technical standpoint, when you're in the OR and you're placing needles, what kind of imaging guidance, or do you use any imaging guidance?
Yes,
when you're placing the needles?
Yes, I think it's very important to know the anatomy on CT first. You have a fair idea of where things are, where the ducts are, where the vessels are, based on your CT anatomy. But then in the operating theatre, you have to somehow translate that into direct vision, which you think is very easy, but it's not. In the operating room, nothing is quite straightforward as you see on CT. It's not black and white. So you do rely on ultrasound to identify your tumor margins, and you identify your vessels and the duct, and then place the needles using ultrasound as a tool.
Do you use biplane ultrasound in the OR, or?
No, single plane ultrasound.
Single plane
ultrasound.
And fingertip ultrasound?
Yes, it's fingertip ultrasound, and we have dedicated intraoperative probes, which are very small footprint, not our usual probes which we use in our practice. They're very small, which means you could sort of maneuver them into the small gaps in the anatomy.
I've been involved in a few of these in the operating room, and the biplane ultrasound has been helpful. So how is the post-procedure care different, obviously, from doing this percutaneously versus doing it in the OR? Can you talk about that?
I think the care is similar as for any other patient who had a pancreatic surgery. So they all have their antibiotics. They all will be kept sort of nil by mouth for a period of time to ensure there's no major flare-up of pancreatitis, etc. And once that aspect of it is sort of understood, then they slowly start to be fed orally. And most of our patients, I think most of our Whipple's patients, stay in the median length of stays of between 5 to 8 days afterwards, and sometimes a little bit longer if they have a collection or a leak or an infection or something like that, but about 5 to 8 days. They are all managed initially in the intensive care unit and for 24 hours, and then they're transferred back to the normal ward for the next few days, and then they slowly start mobilizing, eating, etc., and make sure they're not septic or anything like that. And usually majority of the patients go home at 5 days, but sometimes a bit longer than that. Yeah.
So when we do percutaneous IRE for pancreas, we do our first imaging at 1 month. Given all the post-op changes, do you all have a different follow-up protocol for your patients when you start looking for response?
No, our standard protocol is we tend to do a scan about 6 weeks after the surgery or procedure, just before they can start their adjuvant chemotherapy, etc. So standard protocol is at 6 months, and then they start their adjuvant chemotherapy, and then we do a follow-up at 3 months, 6 months, 1 year, etc. Yeah.
Martijn, you've been involved in designing and executing several very important IO trials, and also in the pancreas space. And many of these have significantly moved the needle for interventional oncology in creating high quality evidence in the pancreas. Back in the years, we talked about the Crossfire trial together, but could not be part of that with you. Can you talk to us about the Crossfire trial, which is a randomized trial that looked at IRE and radiation?
Yeah, so I think if you look back at the Crossfire trial, the most discussions back in those days are just as vivid today as they were then. I mean, there was a lot of discussion, should we compare? So all the patients needed to be, of course, pre-treated with the FOLFIRINOX chemotherapy or Ablation, and then do the focal ablation. But we had a lot of discussion. There was no evidence. There was only one very big trial on conventional chemoradiotherapy. It's a LEP-07 trial, which was negative. So there's actually, until today, no hard evidence that SBRT is, increasing overall survival. So looking back, we did not include a chemo alone arm. The results of the Crossfire trial, so that's FOLFIRINOX plus SBRT versus FOLFIRINOX plus IRE, was completely overlapping survival curves. We had to stop the trial after having recruited, I think, a little over 30 patients in both arms, so I think 60-something patients, because the chance of finding superiority for either SBRT or IRE was less than 20%. So there was hardly any difference. Did that help? No, because now we don't know what to prefer, SBRT or IRE, and we still don't know is focal therapy superior to chemo alone. And we still don't have the answer today. I mean, it's. I think if we learned one thing, it's that focal therapies probably modestly improving overall survival. I still consider locally advanced pancreatic cancer a systemic disease, so a complete cure is rare. But I think if I would redesign the trial now, I would want to have a chemo alone arm in there, even though that would make recruiting patients more difficult, because of course nobody wants to be in the chemo alone arm. But
yeah, you preempted my next question. I was going to ask you if you were going to redesign the trial, but I'd still have another follow-up question to that. If you did have the ability to redesign it, would you just have it similar to the DIRECT study where you had chemo and randomizing to chemo IRE, or would you still have a radiation arm?
Ooh, that's a difficult question. I mean, SBRT, you cannot, everything was overlapping. The only two things that were different was local progression-free survival, so local recurrence rates were not significantly, but with SBRT it's difficult to see local recurrence. But interestingly, we had less, we had a superior distant progression-free survival. So the moment in time where you had metastatic sites in the liver or in the lungs seemed to be delayed with IRE, and this is why we completely shifted our focus away from locally controlling the tumor, improving overall survival, to maybe having a completely new, a paradigm shift to combining it with immunotherapy. So our focus at the moment is in combining pulsed electrical fields with whatever immunotherapy, for example, checkpoint blockers. We obviously did the PANFIRE-3 trial, which was a multi-step trial, but to put it briefly, we wanted to see, do we have durable responses when you do both IRE of the pancreatic cancer plus CPG, which is a local form of immunotherapy, plus systemic checkpoint blockers. And I cannot share any of the data, but this is where we're shifting our focus, because I think focal treatment of the pancreas is modestly improving survival, but we have to do a better job, I think, in the future for these patients.
But I'm sure you could talk about PANFIRE-2, which was a positive trial. And so let's talk about PANFIRE-2.
So the PANFIRE-1 was a safety trial where back in those days we had we had higher complication rates than anticipated, but the promising outcomes if you look at overall survival. So we designed the PANFIRE-2 trial, which was with a predefined endpoint. I mean, patients treated with FOLFIRINOX alone had a median overall survival of 12 months back in those days for the same population. So we wanted, with FOLFIRINOX plus, after the FOLFIRINOX 4 to 8 cycles IRE, we wanted to improve that and have it significantly be over 14 months from the diagnosis, from the first treatment, let's say. And with that 17.2 in one arm and 17.8 in the arm that was pre-treated with surgical resection, we amply met that actually. So it was positive. We seemed to enhance survival by 3 to 4 months. And we also retrospectively looked at a cohort of patients from the other, let's say, academic hospital back then in Amsterdam, patients that would have been eligible in the trial that actually did have a median overall survival of that 12 months and was significantly superior. So that was a positive trial, but we still need to have prospective randomized controlled data, systemic therapy alone versus systemic therapy plus IRE. Yeah.
So is, one of the key competing treatment modalities with IRE of the pancreas is radiation. In the United States, at least in our center and a few other centers, MR-guided LINAC is something that seems to be showing promise. In the Netherlands, is it mostly SBRT, or you are also seeing more MR-guided LINAC?
No, the same is true in Amsterdam. So the radiation oncologists are shifting away from, let's say, conventional SBRT to MR-guided SBRT. I'm not so sure. I think it also reduces their complication rates. Seeing better means treating better, but also having less complications. So the problem is that I think our radiation oncologists, they have 2 machines, but you cannot do all the SBRTs in that, let's say, a very expensive MR-guided machine. But in the trials, we only did MR-guided SBRT. Smart.
Yeah. So I have a general question for all 4 of you. We'll go around the table. We all know when we deal with technologies that involve device and innovative technologies like IRE, is a significant challenge when you want to design and execute a randomized controlled trial. Because patients, when they come to a high volume center, they don't want to be randomized. At the same time, we need to produce level 1 evidence of having data from an RCT. And in the United States, we tried to do that with the DIRECT study. It was an FDA-approved randomized trial, but also had a registry which was going to have a control arm. And our site had both. And again, the challenge was recruiting patients with RCT. Most patients chose the registry, and we're going to see results from the DIRECT study soon. But as somebody who's done several RCTs, what are some of the key challenges you see?
So it's still hard, even in the Netherlands. But I think the only option for patients to get novel, treatments is in the setting of a trial. So I would not be allowed to treat a patient. There's always exemptions, but I would normally not be allowed to do an experimental treatment in a patient. We need to do that in the setting of a prospective trial, and we actually need, similar to drugs, we need to do that first in a safety trial, then in an early efficacy. It can be a single arm trial, and then in a randomized controlled trial. So there's simply no other way, and this is where sort of the routine comes from, that we have to do it stepwise in the setting of the trial. But it's still not easy, but I think that Dutch patients, they realize that the only 50% they have for that novel treatment that they're all hoping for, so I'm not saying this is easy, is in the setting of a trial. Some, they go abroad, so it's not that like the problem doesn't exist. Some go abroad, for example, to Belgium or Germany or maybe probably the UK to get the treatment. But the majority, they agree to stay in the trial even if they are allocated to the, let's say, the non-interventional arm.
Right. Tze, you've been involved in many trials, and given the challenges with RCT, what is the climate for those in the UK? And if you have similar challenges, what are the alternatives do you think we have?
I think in the UK, because I'm involved in NICE guidance, I think that whenever possible, they always encourage clinicians to actually undertake RCT because it provides better, higher level of evidence so that it can actually be embedded within guidelines. However, for some NICE guidance, they know that in certain situations it's not possible to have randomized controlled trial. Then the only way to do it is to actually collect large-scale real-world evidence and to inform practice.
Sure. So, again, what are your thoughts on?
I agree. I think it's quite challenging with all the various guidelines, and it's always desirable to do an RCT and to get that level 1 evidence, but in practical terms, it's going to be quite challenging to both at all levels, right from recruitment to designing and getting the funding, etc. But the second option would be to maintain a robust registry, and also to collaborate between centers to collect the data together and produce a larger series of papers or meta-analysis, and that would be another option of getting the evidence we need.
Sure. Yes, talking about collaboration between centers, our 3 centers are currently working on a collaborative effort on combining data on metastatic colorectal cancer treated with IRE, and hopefully we'll have a good manuscript from that. Switching gears to renal cell carcinoma, you use both thermal and non-thermal modalities, and RCC is a big part of your practice. When do you choose IRE when you have to treat an RCC? What kind of criteria do you use?
Yeah, I think that when we started using IRE, it was a very interesting time. It was in 2015 when we have a patient who's a VHL patient, actually have both RFA, cryo, and then he just happened to have one tumor sitting in the renal pelvis, next to the vessel, next to the pelvis. And I remember looking at that case and then thinking that I can palate perfuse, I can do anything I like. If I use thermal ablation, it will obliterate the renal pelvis and the patient will lose the kidney. So at that time, it was still off-label IRE in renal cancer. So we have to write to the board, ask permission, whether they will consider with the consent of the patient. The actually information governance board actually provided us with approval. So we did our first case, and it was filmed by BBC in the UK. And it was very interesting because that was our first patients that we did. It was successful. It was in the news. The patient actually was really grateful to have that procedures and that area remained well treated for the subsequent follow-up for the next decade. And then so after that, it kind of changed our practice. So for all the tumors that is cited in the centrally located place, we tend to, use IRE for their indications, and or it's close to very awkward structure. We find a hydronymal dissection may be difficult, so we use that. So over the years, we collect our experience, and we have published our midterm results. And as we all know, the results out there are quite limited. Up until today, the whole system I reviewed about less than 200 cases in the world. So, we are hoping to have a collaboration between the sites. So.
Any special techniques you use when you do kidney IRE, or is it similar to your thermal ablation?
So in renal IRE, as you know, Raj, I probably have, because of the complex cases we do, as the series that I published, we have one uretary injury. So I learned that regardless of any energy you use, you have to be intentionally mindful when you're very close to ureters. In our practice now, we always stent all our patients, whatever thermal or non-thermal ablation, we stent all the ureters with uretary stent. So once it helps you to demarcate what the ureter is during treatment, and the case that we have uretary injury, we publish our experience so to let other people learn from it. That particular situation is because we have a surge of electrical energy. We suspect that it's probably going to thermal range and causing the injury. So I think we discussed that case because I brought that case to you and asked you, from how can we learn from it. And I think that you have provided some very insightful thing. We say, when you put two needles, the one closer to ureter always set as positive, so it fire away. So that's what we do. We haven't had any other cases that we uretary injuries, so we like to keep that record as only one case ever in our practice.
Great. And do you use any I don't use displacement techniques, but do you do those when you do IRE in the kidney?
No, it's just the uretary stent be helpful, and then intentionally set that as a positive, and then it fire away. And we have done many cases since then, and there were no issue.
So yes, you pointed out the limited data for RCC and the need for collaboration, and we have our center and yours in Madrid collaborating. Can you talk about that project?
Yeah, I mean, we are inspired by Martijn, all these acronym for all the studies. So the study is known as REWIND. It's a retrospective analysis between Miami Cancer Institute, our institution, as well as Madrid. And in fact, the paper is now being revised. We resubmitted to CVIR as of this week, and it will be one of the largest series that in the world. Hopefully it'll be accepted. 68 patients, 31 renal tumors, and actually, just like you say, it's repeatable. Although that the first treatment IRE may not achieve the kind of conventional renal cryoablations or local control, but the overall local control is around 96%, which is good.
Yes. So for us in the United States, sometimes we do get pushback from insurance companies for authorizations for IRE, and we have to do peer-to-peer. Do you all have similar challenges in Europe, or is it a different system completely?
So similar challenges, yeah. Often insurance companies, if it's not a standard of care treatment, or if it's not a nice recommended treatment, they want a letter of explanation, and they discuss it among their own scientific board whether that justification you provided is acceptable, and only then they'll approve. So you can contest it, but it can go either way. So sometimes they will not, sometimes they will. So, yeah.
In the Netherlands?
So in the Netherlands, what helps is there's a generic code for ablation, which means that the hospitals, they lose a little bit of money, but at least that generic code, it covers, let's say, 75% of the complete IRE procedure. We did manage to get a healthcare activity code. No reason to get into the details, but for HCC and for colorectal, liver mets, and also for prostate. And now we're working on making the reimbursement amount higher for IRE because it's more expensive. But we could still do it and get at least 75% of the costs back from the insurance companies. That helps.
Right. So I haven't asked this question to three of you. What, in your opinion, would a young IR have to do to build an IRE program?
I think first thing is somebody who should be really passionate about IRE. IRE is a complex technique, obviously, so you need to really understand IRE, you need to like IRE and push IRE. So that's the number one thing, and then it's just a matter of inspiring his clinical team, the MDT team, to refer patients to him. And I always say start off with the simple, straightforward cases in the liver first, produce consistently good outcomes, and that'll build confidence among the referring teams, and then you start doing sort of more complex cases as you go. So yeah, start small and then gradually build up, and the practice will establish. Yeah. Mm-hmm.
Yeah, I agree with everything that's been said. I think that it's very important that if I hear Prof talk earlier, it complements other ablation technology. So you will not sell IRE standalone. You'll be part of your practice. But having it will complement. And I think working with the MDT is very important. I remember only recently, so we have IRE in our practice now for more than decades, but the liver IRE only very recently accepted MDT that our colleagues, our MDT colleagues, are comfortable with me suggesting that actually, if everything else fails, would you want to consider IRE? They now are happily accepting that as an option, but before they would turn around and just say it doesn't have enough evidence. So I think it is very heartwarming to hear that after sitting MDT for over a decade, IRE is now being accepted as part of the discussion.
So in the world of interventional oncology, we're seeing more and more technology creeping into our workspace. And among the 5 of us, 4 of us have a robotic program. What, in your personal experience, has been the impact of that, especially on your IRE practice? I started with Varshana.
I mean, I think we may have mentioned this earlier, but one of the biggest technical challenges of IRE is probe placement. I mean, that's really the crux of the issue. And when you have robotic assistant, it kind of levels that playing field too. We maybe mentioned earlier, now we're enabling younger physicians, trainees to be able to place probes. Sure, the attending has to do the planning, and that's where a lot of, the advanced thinking and organization goes in. But once you have sort of your plan, now you're obviating the technical challenges of placing the probe with the robot.
Yeah, and we're still in that learning phase but I can see the obvious benefits of that. I think, as Varshana has mentioned, IRE takes away that learning curve of probe placement. Sorry, not IRE. The robot takes away the learning curve of probe placement. So you could have years of experience trying to put the probes in, but with the robot, you only just need to do a handful of cases, and you're there. Aside from that, there are also definite patient-related advantages. The number of needle punctures, needle repositionings is less, so the postoperative pain, the trauma complications are less, and the radiation exposure, not just to the patient but also to the operator, is less as well. So there are benefits of the robotic program, but yeah, it's something, again, as a team we have to embrace it. It's there. I think it's only going to get better and better as we start using it more. So yeah, I think the more we are able to accept it, it's a big change for somebody who's never used any guidance programs to ultimately completely rely on robot to put the needles. It's a massive mindset change, and that's a part of our learning curve as well. So I think once we get there, I think it's there to stay. That's my view. Yeah.
And have you used it to do IREs or still thermal cases?
No, we use IRE. In fact, one interesting observation, if I want, we have a few people in our team. One of my colleagues doesn't like to do IRE very much, but ever since the robot come to practice, he's been doing all the IRE cases with the robot. So I think the robot has a lot of contributions in the ease of placing the needle, I think.
Yeah, it is definitely has a learning curve compared to thermal ablative techniques, getting them parallel, the spacing, the 3D reconstruction and all that. So having an added tool, say a navigation system or robotic assistance, I agree with all of you. I think it's going to get more and more mainstream. So do you all use ablation confirmation software after your ablations? And
for the liver, always. For the pancreas, we do use it, but it's very hard. You can only see the margins in that part of the pancreas, like the pancreatic tail, but the rest has no margins, so it's more difficult there.
We do use it for all of our ablations too.
I like to say we use it, but we don't. I'd probably say we would use it in 50 to 60% of the cases. A robot comes with its own ablation confirmation software, so that's where we use it. The other ablation confirmation software is the Ablate software, I think, that Siemens provides. So that's something which we tend to use as well. So yeah, to be honest, we don't use it for every case, but I think that's where we're heading. We're slowly heading into using it for every case. But as of now, we probably use it in about 50 to 60% of the times. Yeah.
see.
We use it all the time now. It's actually, it kind of shift change ever since last year. We managed to bring everyone on board, and even those reluctant here, but realizing that actually doing the contrast second time around and then repositioning I think especially with all this guidance system, it make it reposition faster and easier. So I think most people are really, enjoying in fact the confirmation software to making sure it's better outcome.
So once again, we'll go around the table, but Martijn, if you want to see some improvements to IRE technology as what we have today, what would it be?
Well, having listened to the four of you who do have the robot, for me that's an easy answer. No, I'm a strong believer in the robot. I'm just struggling for that initial phase where probably my results will be a little bit less, and then after But I see that it will democratize, the robotics and the confirmation software that will democratize what we are doing, and that should be the next step, and we should standardize that, but we're not there yet.
In IRE, with the current third generation system, or there are other devices now that are currently available, with this technology, if there's some improvement that you would like to see, what would it be?
I think that there's always very attractive to things that if you only need to place one needle, will do everything, and then I'm not sure that will actually happen, or to create kind of the zone ablation that we require.
In the bipolar,
yeah,
to have a bipolar. We did have it, and then it was taken off. I feel that would be a good one to bring back, to have a bipolar needle, and you mentioned having a bigger ablation zone. Yeah.
I completely agree. I think it's been a while since there has been a major sort of hardware improvement from the IRE side. So I do wish to see a couple of things. One is the probe design to be better, including getting a bipolar probe is one, and also technology-wise using high-frequency IRE. There's something which we have also talked about for a while now. I hope that does get some traction, and that gets sort of the attention it deserves, because that'll eliminate quite a lot of things. That eliminate the muscle contraction aspect, so the procedure will be shorter, and you don't have to use ECG synchronization, so which again makes the technique much faster as well. So I'm hoping those two things would come on in the next sort of few years, and that'll make the process a little bit easier and the technique simpler. Yeah.
Varshana, what would you like to see? It could be hardware, software.
I would say if you take robotics and jet ventilation off the table, the most difficult or challenging part of the actual probe is the length and weight of that cord. I think that people underestimate how much the weight of that cord can change your needle trajectory. And so now I think with jet ventilation and robotics, it makes that easier, but there is still a little bit of, you have to be cognizant of that, of how much that can drag your probe and change your trajectory. So making that smaller, lighter.
I think that's a very good point. I mean, the other machines, the electrochemotherapy machine, which is actually a sister machine, I would say, it has a different probe design where you put the probes in, then you connect the actual cable to the top, which makes it very significantly easier and simpler, because the patient is going out of the scanner. You don't have to worry about all these cables. So that probe design, I did mention it to the angiodynamics team a while ago. But anyway, so hopefully they will.
So next one, to wrap up things, thank you very much for this insightful and detailed and wonderful discussion. I want to leave the audience with more of a forecasting question. In your opinion, where do you see IRE down the road?
Well, I think if we take the example of what happened in interventional cardiology, where now the standard of care, if you have an arrhythmia, is actually a post-electrical field ablation, it has the potential to do that. I mean, like we all said, I think the recurrence rates are currently, it's worse than thermal ablation, but it has the potential to actually surpass that. So it comes down to, I guess, investing in, improving the electrical pulse domain. So I see a bright future, but it will require a lot of investment from people, who will have to design and do better job.
What do you think, Pro?
I completely agree with Martijn, what Martijn has said. I think IRE has got the potential to change the game completely, provided the right investment and right sort of research goes in, right research and development goes in. It can change. As you mentioned, the probe designs is a significant factor in that. High frequency IRE is a significant factor. All of these would make the technique simpler, and which means more and more uptake, more and more people will take it up, and that means more and more evidence would come. And I think that'll help in terms of establishing the technique more widely.
So do you think ablations would be a standalone technique moving forward, or are we going to see more combinations?
I think that it will be more combinations, because we almost like part of the wider pictures. And as we are now becoming part of the MDT, cancer MDT families, I think they recognize that we have a role to play. It's there to complement them, to make the patient outcome better.
Varshana, you have the final word.
No pressure. I think, one of the biggest hindrances to anybody getting started in an IRE practice is, we talk about difficulty of probe placement, length of the procedure, but with integration of robotics, I think that really takes away that large obstacle. And now we're seeing, like we said, we're democratizing probe placement. Now if you have a second-year resident or fellow who's able to place probes, what's really stopping you? I think it takes away that large obstacle.
Okay, great. So thank you all once again, and on behalf of Spectrum Cancer, thank you for joining us for this discussion on IRE, and have a good evening.
All right. Thank you very much.
Thank you.
Thanks.
Hello, everyone. Thank you for joining us at the webinar. We're now here in the Q&A session, and I'm joined by some of our faculty members, Professor Peddu, Professor Tze Wah, and Dr. Varshana Gurusamy, and Professor Martijn Meijerink couldn't join us. So we have a few questions from the audience, and the first one is I think would be probably better for Dr. Tze Wah to handle. The question is about your renal protocol that you use during IRE of the kidney.
Good. It depends on where you are. Very good morning or good afternoon or definitely good evening from where I am. So thank you for the question. So this is about the renal protocol for renal IRE. So in IRE, we will select the patients that usually wouldn't treat them with conventional thermal ablation. So the tumor is typically centrally located close to vessels or close to ureters or renal pelvis. Or if it's in a very awkward location, such as if it's anterior located and you don't think that you can successfully hydroneural easily, then you may want to consider IR in that locations. So those are the cases we typically select. And we also know that the tumor size is very important. And when you actually go above 3 centimeter, based on our experience, you have to be intentionally mindful that you want to consent the patients for more than one treatment session, because just in case you don't adequately achieve the margin, you can come back and repeat the treatment.
And actually, to elaborate a little bit, Z, actually during the procedure, like the positioning and all of that for kidney is slightly different. I'm assuming most of these will be prone. Do you do any? You'd mentioned during the webinar that you do stenting for all these patients. Is it you go with the nephroureteral or internal double J, or is it just a nephrostomy?
So for all patients, that because of the just as Raj just mentions that because they are centrally located close, we want to protect ureters. So we traditionally now just stent all patients. So they have two settings. Both so they'll go to urologists to have it stented. Usually we like it at least 2 weeks before procedures. We cover in antibiotics so that because they have an intervention. So when they arrive to us, the patient already have the stent in and are just symptom free for any evidence of UTI. And then we do procedures. Depending on locations, most of the patients either prone or lateral, but most of the patients are prone in our cases. So so for any prone position, it's very similar to cryoablation. You place patient prone, you have to make sure the patient is protected from the way that they have a prone view that protect the face and eyes and making sure they pat them correctly at various pressure points. So those are the considerations required.
Okay, this is not from the audience, but this is for just from I'm asking this. So in our practice, we use IRE just for central RCC, or if it's close to critical structures. For the rest of the cases, we use cryo. Is that the same for you, or or you use IRE for most of your?
No, that's testing for us. We use RE as problem solving for centrally located tumors that we thought there's too close viral structures. We couldn't use dermablation, cryoablations for viral reasons. Then we will use RE. And sometimes if the tumor is quite large, and then the margin is close, we know that even if the tumor is large, you have to plan for more than one treatment session. So sometimes we'll consider to explain to patient actually the margin that close the viral structure, we'll try to aim treat whole tumor, knowing that posterior margin away from viral structures, we can come back to do salvage cryotherapy. That's why the paper they were publishing that hopefully is the last round with the reviewers. We showed that there are a few patients that require salvage cryo, working on that principle.
Got it. Next question is, have you seen changes in the biliary ducts when you treat liver tumors close to them? Prav, you want to take that or? I can give my opinion too.
No, I think you do have to take some precautions when you are treating very close to the bile duct. My sort of rule of law is I just try to stay at least 2 to 3 millimeters away from the bile duct, so that because you tend to get a bit of a thermal heat around the needle tips. So you can get up to 30 degrees. I think Martijn has demonstrated that previously in his papers as well. So you do have to ensure that your needles are at least 2 to 3 millimeters, preferably 5 millimeters away from the bile ducts, so that you don't cause any temporary thermal stricturing of the ducts. Yeah, that's the principle I follow. Yeah.
Well, I do the same thing. Just to add one additional point, when the probe that's closest to the bile ducts, we make sure that the polarity is set to positive on that. Typically, based on, again, bench studies from the Netherlands, you have slightly less thermal effect from the positive polarity probe. So that's how we handle it. But of course, giving some safe distance from the duct, usually a few millimeters, has also helped. Quite another one is, do you use ablation confirmation software routinely? We can go around for all of us. So,
At the moment, we are not using routinely for every patient, but we are soon going to. We have, as I mentioned in our webinar, we do have the ablation fit from Siemens, which we are trialing at the moment, and that seems to be working well. But it hasn't sort of filtered onto using it for every patient as yet, but we are using it for maximum number of patients.
Tze, Varshana.
Hey Raj, hey everybody.
Hey.
So we do use ablation confirmation for all of our ablations, and we started using it in the pancreas too. I think maybe we'll talk a little bit about robotics and the software on that is super helpful. But as a group, we tend to use it for everything.
Right. Tze?
Same here. I mean, I think it's very helpful now, especially robotic. You can go by reposition fairly, easily. We, we do a contrast enhanced examination, making sure the margin is looking good, and so that I think that it's very helpful.
Yeah. So we used a third-party software before, but after introducing the Epion, we use the software that comes along with that for the margin confirmation. A couple of more questions. One is about jet ventilation. How do you perform your ablations? Do you use jet ventilation? In our practice, we use general anesthesia. We don't have jet ventilation in where we practice. You guys can comment on that.
I can talk about that. So I tend to use jet ventilation a lot. I think in the beginning I was using a lot of general anesthesia, but in an area like the pancreas where there's can be some breathing motion, it's nice to have jet because you can really plan your trajectory with minimal disturbance from breathing, and then in combination with the Epion robot, it's really nice to have jet because you're not waiting for that end tidal to drop to zero every time, and it really helps the case go a lot faster as well.
Okay, great.
If I can add on that as well, we also have jet vent, and unfortunately, only half our anesthetic team are happy to use it. Some of the other consultants are less trained in using it, so we use it sparingly, specifically for IRE cases. We tend to book IRE cases with that particular team of anesthesiologists to ensure that we get the max out of it. Especially for IRE, when you're putting multiple needles, it really makes the process a lot more simpler and easier if you have jet vent.
Great. See?
So like you, Raj, we haven't got it yet, but we are in the process of procuring. So I'm looking for the user, but at the moment with the robots, we just suspend respiration, we just put a needle, it works very well. At the moment, I'm sure that with the jet and ventilation, it should be a massive improvement.
Great. One last question, and we can go around. And how has the robot impacted your IRE program? I can go last. I'll wait for all of you to finish.
I think for me, the robot. helps me understand what's possible. A lot of times, we're going off plane and we have software that, is integrated with our CT scanners that helps you think about going off plane. But I think that robot takes that to a different level. The ablation like planning software is incredible. It's really well integrated. And so you can see like, if I'm going to use 3 or 4 probes, what is the true ablation size that I'm going to get? And then, along with jet ventilation, I think that really you really see the pre and post well because the images match up really nicely. But I think it's really helped in a tricky area like the pancreas. It's really helped me see what's possible in terms of trajectory. And then, being able to place probes singly, in one single pass also helps, cut down on time.
Yeah, I can go. I can go next. I think that I echo what Varshana say. I actually think that it has transformed our practice. Certainly, it facilitates some multiple needle placements, and some of my colleagues find that one needle placement, especially IRE, is, when compared microwave, you only do 1 or 2 probe placement versus 4 to 6. I think that the robotic program actually transform our practice. And certainly, just as I said, it's really good to be able to do off plane, but very accurate. You can democratize sort of younger trainees who can replace pros as accurate as senior consultants. So I think it's truly is it's revolutionized the way that we practice in the way that we offer the treatment to our patients.
Right, Prav?
The same, echo all the points. It definitely takes that learning curve out of the equation, specifically for those who are starting an ablation practice. It's particularly helpful in off-plane ablations, particularly lesions near the dome of the liver. And if you're wanting to do IRE as well, if you're wanting to put multiple needles, it makes a significant difference in terms of the speed with which you can do the less number of needle repositionings, less radiation to the patient and to yourself as well if you're the operator. So yeah, it adds a new a dimension of ease to the actual procedure, specifically with IRE. I think.
No, I call that all of you said similar experiences. Our trainees are able to place IRE probes, off-plane placements, all of these with relative ease, and it's made a big impact. I spoke too early. Looks like another question popped up, and that is about IRE in HCC with immunotherapy. Prav, you want to take that?
Yeah, I mean, it's still in a very much in a research phase at the moment, but I think there are a few papers out there which suggest a few early papers, very pretty much in the experimental studies actually, where if you use a combination of IRE and then supplement the patient with immunotherapy, you can potentially use IRE as a primer. It works. I mean, the research which I've read is mainly in the colorectal field and also in the pancreatic cancer field.
Gotcha.
It's less so in the HCC aspect, particularly those chemo-resistant tumors. You can IRE tend to sort of release the antigens from that, and that stimulates the immune system. And if you supplement that immune response by adding, checkpoint inhibitors or NK cell inhibitors, etc., you can augment the response, and it can provide much better tumor necrosis and tumor control. But it's still very experimental. But I think that's one area where we will probably see a significant growth in the coming years, as we tend to know more and more about immunotherapy, and we discover more and more drugs. I think that's the area which I think will continue to grow, specifically in the field of colorectal mets and also in the pancreatic cancer setting.
Right. So I guess that brings us to the end of the webinar. Thank you very much for all your questions, and thank you for joining us, and thank you for AngioDynamics for helping putting this together. So thanks a lot. Have a good day. Enjoy the rest of your day.
Thank you very much.
Bye.